Thank you very much, and thank you on behalf of my colleagues and collaborators for the funding, and thank you for the opportunity to present a brief overview of our project. So in the blurb that you heard at the beginning, I think we said it was 200 million patients undergo surgery. It's gone up 100 million in the last 5 minutes. But the latest estimates suggest that it's about 300 million patients undergo non-cardiac surgery, so non-heart related surgery worldwide every year. And of course that's fantastic treatment, saves lives, improves lives, but it comes with a risk. All surgery has some risk, and the most common complications of surgery are cardiovascular complications. In fact, it's estimated that they account for about a third of the mortality that's seen after surgery within the first 30 days. And the most common cardiovascular complication is injury to the heart. And about a third of patients, if you look carefully enough, undergoing major non-cardiac surgery will have evidence of injury to the heart after surgery. And that in itself causes complications, but it's also a harbinger of other complications and a harbinger of death. So if we could predict accurately cardiovascular complications, and in particular myocardial injury, then we may have an opportunity to intervene and improve both cardiovascular outcomes and general outcomes in patients undergoing major non-cardiac surgery. But unfortunately, predicting myocardial injury in this setting is very difficult. And that's because it's a very complex situation, and there are many things going on all at once in an individual patient. And this slide shows you some of those things. There's the factors that a patient brings to the operating theatre: their age, their pre-existing cardiovascular history, diabetes, renal dysfunction. And they obviously have a major effect on the risk of surgery. The type of surgery itself and the setting in which it occurs, whether it's elective surgery or emergency surgery. So they all, of course, predict your outcome from surgery, important predictors. But then there's a whole range of other factors that predict your outcome. Intraoperative factors, whether you bleed a lot, become hypoxic, and then the post-operative factors as well. And they're very important. And I'll come back to why they're particularly important. And of course, in one patient, it's not just the preoperative factors, it's the whole gamut of factors. In one patient, there'll be a whole range of these things happening at once. And then the pathways to myocardial injury are also diverse. There's two main pathways, but very simplistically, we think of it being atherothrombotic, the same way that we think of normal heart attacks. An atherosclerotic plaque ruptures, a thrombus then forms on that ruptured plaque and causes disruption of blood flow. But in the surgical setting, there's another mechanism, what we now call type 2 myocardial infarction and myocardial injury, which is supply-demand mismatch. You can have a completely normal heart, completely normal coronary arteries, and still suffer myocardial injury if you lose a lot of blood, become very hypoxic, become very tachycardic. So there's these two ways in which myocardial injury occurs and a whole range of factors causing these two pathways. So it's understandable why this is complicated, why it's difficult to predict this injury. And the problem's really multifactorial. Predicting myocardial injury historically, we've had to simplify things down. Doctors like things simple. We need to simplify a whole lot of complex information, distill it down to a few risk factors that we give a point to, and we then have a scoring system. That's useful, but it only gives us part of the picture. And importantly, most of the scoring systems only use that first group of factors I showed you, the preoperative factors. That's useful to tell you the risk of a patient before they go into the operating theatre, which is helpful to inform the patient and their family. But the problem is, most of those things are not things we can do anything about. We can't change your age. We can't make you non-diabetic. We can do very little about your renal function. We can't stop you having your heart attack a year ago. So it's actually difficult to modify that risk, which is what we need to do. So if we were to go back and think, well, what's the ideal way that we want to look at perioperative risk? There's some characteristics of a risk prediction system. I'm not going to go through all of these, but these are the things that we would look for in a risk prediction model. And there are novel techniques which can enable us to do a lot of these things. And artificial intelligence, machine learning, ticks a lot of those boxes. But even that's not enough, because for those systems to work, you need the data to come in, and that's part of what a modern health system needs to be doing, is providing the data that allows these technological advances to actually be used. And we're very fortunate at Royal Perth Hospital, because of the foresight of very many people, that we have got some of these systems. So what we want to do is try and use these systems, along with some excellent collaborators, to try and develop a better system to predict perioperative myocardial injury and other cardiovascular complications. Now, this is a complicated slide. This is just some preliminary work that was led by Janis Noldi, who's one of the investigators, now back in Germany. Worked with Marcus, PhD student, fantastic colleague and investigator. And really say it's slightly complicated, but this is really proof of concept work that we did, and we were very fortunate. We had collaborators from many countries. We were able to pull together a data set of 25,000 patients who'd had serial blood testing after non-cardiac surgery to look for myocardial injury. And what you can see here is that as you add information, these are blocks of data, and this is your preoperative risk factors. This is if you add in some immediately preoperative blood tests, some other data, what type of surgery is happening in what circumstances. And this is adding in just a very small amount of intraoperative and immediately postoperative data. Really small, because in the data set there is only very limited information. But as we move across here, we see the improvement in what we call the area under the receiver operating characteristic curve, which is just a measure of how good your system is at predicting something. And you can see that as you add more information, not surprisingly, you get better at predicting things. And these are the ROC curves here. And this method is better than traditional methods, but it's by no means perfect. It needs a lot of further work. But this is something that proves the concept that if we do add in more information, and particularly that intra and post-operative physiological information, we can hopefully improve our predictive accuracy and thereby improve our ability to intervene and reduce some of these complications. So this is the plan. This is what we're very grateful to be funded for. What we want to do is to look at other techniques, other machine learning techniques, to develop these, validate them, using patient data locally and eventually patient data elsewhere. And ultimately what we were looking to do is to automate that data collection and then use it to not just provide the preoperative risk, but to give you an iterative idea of that risk. So you can watch the risk of a patient through their journey, through their operation and beyond, and see when that risk is changing, and identify sooner, hopefully, patients whose risk is changing. And then ultimately, we hope that using AI, we can have systems that will warn clinicians and tell them why that risk may be changing and what they need to do to try and intervene and hopefully avert some of the problems. So thank you very much to the Royal Perth Research Foundation and to the Fiery Fund for funding us to do this work. We're excited, and hopefully we can make it a reality. Thank you.